Okay, hello again. My talk is on MRA of the abdomen. We've talked about the aorta. We've talked about the renal arteries. So what's left for me to talk about a little bit more are the mesenteric vessels, so I'll focus on those. Let's see. My movie working? Or not? Okay. Just aesthetic. Anyway, so basically, one of the things we're going to talk about is really anatomic variation. We talked about that in renal donation, but also in liver donation. It's very relevant. It's also important to understand anatomic variants and how they have impact on treatment planning, but also on tumor staging, because involvements, again, of the arteries in pancreas cancer, for example, encasement of the arteries for that, or for liver tumors and invasion of the of the hepatic veins by tumor can preclude certain therapies or make therapy more challenging, interventional therapies more challenging. Another area of interest is mesenteric ischemia. In the acute setting, we tend to use CT, but for chronic mesenteric ischemia, on patients who are sort of compromised, often have renal disease as well, we will employ MR. It's like a weird noise. Other things are vascular malformations, which were also kind of referred to earlier. So some of the challenges in the abdomen have already been talked about. Really, in order to evaluate the various abdominal structures, you really need a larger volume of coverage. Sometimes you not only need to see the vessels, but you also need to see the organs and see the relationship as well as the impact on perfusion, like we saw with renal, but also on liver lesions and things like that. So we need kind of a large volume of coverage. We have respiratory motion to deal with and cardiac motion, particularly at in the left lobe of the liver. There's often artifacts you have to deal with as well when people have undergone surgery. And so CT and ultrasound are often the mainstay because they're readily available, speedy, and you can evaluate the bowel very well with CT, and they're very accurate and low cost. But MR, of course, has the advantage of no radiation. The multiphasic imaging becomes very important in order to catch the bolus to get peak arterial, but also to look at venous or any kind of altered perfusion. And you can also, at the same time, characterize liver lesions. Our sequences that we tend to use are contrast. We also tend to use contrast-enhanced MRA, time-resolved, combined with high spatial resolution imaging. Non-contrast options tend to be more so the steady-state precession type techniques. The phase contrast is less frequently used, and time of flight is problematic because you can't really see the branch vessels well unless you cater the slice particularly to that one vessel of interest. And because we're usually looking at multiple vessels, it's better to have something that can have more coverage. And again, we use complementary sequences. Really, in the abdomen, it's hard to separate MRA from MRI. They're very much related, and it's very important to understand that, and it makes it very challenging because it's usually just not one or the other. So as we allude to this, as we move forward, that's something in terms of protocoling and in terms of how we advance the MRA, we need to also think about the cross-sectional imaging as well. So in variant anatomy, it's very relevant particularly in liver donor planning because we either use the right lobe or the left lobe. Some places just still use the right lobe for donation. In addition to having enough volume, the patient also has to have anatomy that is favorable. And the favorable anatomy will be less anastomoses. The more vessels and duplications, the more crossover between right and left, the more problematic splitting the liver will be, and therefore we are very important in the CT and MRI to try and figure out whether there's enough sufficient volume of the liver as well as it's going to be a safe surgery. So we're very critical in that clinical decision making. And again, also for treatment planning, targeted therapies, it's helpful to, when you have a liver lesion, to know what its blood supply is and if there's variance in that blood supply, so that instead of having to waste time and increase the exposure to radiation for the radiologist as well as the patient, you really want to be able to tell them the pathway to treatment. Also in oncology, again, staging, vascular involvement is very relevant, particularly for pancreatic cancer and liver staging. And one thing I probably won't have time to talk about is also reconstructive surgery. We're looking at abdominal wall vasculature for flat planning. So for plastic surgery and reconstructive surgery, the abdominal wall vessels and muscles become very important as well. So with liver donation, the demand really reaches the supply. So we rely not just on cadaveric transplants, but also on live, living donors. Most of them are related, but now there's a lot of patients a lot of volunteers actually who are not related donors. So again, like I mentioned, volumetry is very important in the anatomy, not just the arteries, but veins, bile ducts. And we use a combination of MR and CT in order to really delineate the anatomy. MR and MRA can be sufficient most of the time, but CTA really gives you more detail of the hepatic artery. And oftentimes there's a bit of a lag as they go through the process, and they may want to reassess volume, so they use the modalities complementary. And again, what we're looking for is multiplicity. Here we have duplication on the right and 2 left renal arteries, so that makes it more challenging. And while a skilled surgeon may be able to deal with this is something that they have to decide and know in advance to know what the risks are. Any kind of crossover, when you have any vessels that cross from the right to the left, will probably be a contraindication to surgery without compromising one lobe or the other, because the most important thing is to protect the person who's donating. And anytime there's an unusual course, this is a CT image, but it's trying to show, we've had a couple cases like this where the bile duct is the hepatic artery wraps around the bile duct, making surgery very challenging. Unless they know that in advance, it could really complicate the surgery, and that's very important as well. In terms of CTA versus MRA, again, you'll see CTA can give you some of those more details in the branch vessels, but most of the time what we're dealing with that we need to know about are the more proximal branching vessels. So we often will rely upon a combination of the non-gadolinium techniques, and if that's insufficient, we'll do contrast-enhanced techniques. And so just another example where, in this case, CT was a little bit late timing, MRI was superior, but even with, again, the larger vessels, we can see through some of venous contamination. But again, timing is very difficult, and sometimes with MR and with CT, and so having multiphasic imaging with MR gives you sort of an option to have a couple of tries and hopefully be successful. Again, same thing in terms of multiplicity and crossover is relevant for the venous anatomy. They're just illustrations here taken from MR and CT data, but we'll talk more about arteries today. And also we use hepatobiliary contrast more and more, which makes the arterial phase a little harder to capture, but allows us to get really great imaging of the liver in the delayed phase where the liver is enhancing, and you see sort of reversal. You see black blood, really nice black blood imaging of the hepatic veins, and look for accessory hepatic veins. Again, some of those may need to be reanastomosed in the recipient. So as I alluded to, it's really important to understand there's a combination of things that you want to know for these patients. So a lot of times you're not only looking at the vessels, you're looking at arteries, veins, and the parenchyma. So it's just a liver donor. What we try to do is, even with our 3D fat-suppressed gradient echo sequences, which is really the mainstay of our abdominal imaging, we will acquire them axially in transverse plane, but we really want isotropic voxel so that we can reconstruct and look at the arteries and extrapolate an MRA and MRV. And that is challenging unless you use more accelerated techniques. And since they're becoming more available, and that is very helpful. But even these techniques, these are non-Cartesian techniques. We've heard about radial imaging. This is an example of spiral imaging borrowed from Martin and his group. And the idea of being able to do really rapid isotropic imaging is really kind of what you want in the abdomen, so that you can get an arterial phase, you can get the venous information, you can look at the lesions that you need to look at. And so it kind of, from there you can extrapolate all that you need and get additional information. Even here you can see bowel motion and have better imaging in the bowel. So that's something, I think that's the direction we would like to go, in addition to being able to quantitate perfusion. So as I mentioned before, when you are dealing with treating lesions such as this HCC, hepatocellular carcinoma in the left lobe, this patient was particularly challenging, and even though it's not a dedicated MR angiogram, we have a nice arterial phase to see what's going on. And in this case, there's, if I can slow it down, in this case there should be a celiac and an SMA, and what's going on here is that the celiac artery, which is up here, you can see that there's a gap here, there's an occlusion of the celiac, And so getting to the lesion may be very difficult if you can't get through that vessel. In this case, the SMA is taken over, and there are a lot of collaterals here that are supplying basically supplying the left lobe branches. And so that's very important to know in advance. In this case, it was really extra complicated because a lot of the collaterals had developed varicose, aneurysms as well. Sort of these tortuous aneurysmal collaterals were what they had to get through in order to treat that left lobe lesion. So they had to really cannulate all of that to try and treat the lesion. And knowing that in advance and knowing that it's going to be a major challenge is very important for the patients, for the ability to do this study. Another application is mesenteric ischemia. When the blood flow is cut off to the GI tract, it can be very deadly, particularly in the acute setting. It can be usually a patient has underlying vascular disease and they have an embolic event or thrombosis. Occasionally venous thrombosis can occur, or even low flow ischemia. Rarely aortic dissection and vasculitis can cause acute ischemia. But again, in the acute setting, we kind of rely more on CT. It's readily available. You're ruling out a differential of other things. But in the chronic setting, which is a little bit harder to diagnose because it's these vague abdominal pain, weight loss, can mimic sort of cancer symptoms. It can be hard to tell. But so MR is very helpful to look for stenoses in the patient who's atherosclerotic, but also for other causes. So just a reminder of the anatomy, there are really three vessels I'm referring to: the celiac artery, the superior mesenteric artery, and the inferior mesenteric artery. You can see the vessel size is quite small, so you have to have sufficient resolution to see the vessels well, and that they have different roles and different distribution of their supply to the bowel. And there are collateral pathways, which we sort of saw a little bit of. We saw some of those pancreatico-duodenal collaterals, and from between the SMA and IMA, there's the arc of Rioland and other collaterals. And so these are important to recognize. Sometimes it may be difficult to appreciate at first that a vessel is occluded or compromised, but the presence of collaterals may hint to remind you to look at the vessels and to find the abnormality, even if a patient is not having a dedicated angiogram. So this is just an example of a patient who has multivessel disease, and it really, what happens is it's the multivessel disease. Compromising one vessel may not cause symptoms. Compromising two vessels starts to cause symptoms. So in this patient has a lot of irregularity and severe stenoses in the celiac and SMA. The IMA is probably their best shot of getting flow to the bowel. And in this patient, they underwent SMA stenting. That wasn't necessarily sufficient. They went on to have celiac stenting. And after stenting, then you may choose to go towards CT to see complications of the stent, because sometimes the stents can cause a lot of artifact. But you can go either way. Another cause of pain and sometimes ischemia, not really ischemia, but more pain and problems with eating, postprandial pain and things like that, is median arcuate ligament syndrome. And there's sort of controversy exactly the etiology. Normally, the ligament the median arcuate ligament, it's part of the diaphragm, can compress your celiac artery naturally as you inspire or expire. So depending if you're using a breath hold or an expiration, and this is sort of end expiration versus breath holding, in inspiration, you can see a big difference, and it should really reverse, and patients should be asymptomatic. But sometimes that narrowing is fixed, and it's often a patient who doesn't have atherosclerotic disease. It's really just due to that anatomic abnormality or a variant. And so while it occurs not that infrequently, it's rare that you actually develop symptoms, but this is also important to recognize. So you want to be, if this is something in the differential, you want to make sure that you're looking at inspiration and expiration. And again, because of MRI, being able to use non-gadolinium sequence, be able to repeat, over and over again, you can really look at a patient with inspiration and expiration. Another etiology of compromise of the vessels in the mesentery is vasculitis. There's many different forms of the vasculitis, but mostly in the abdomen we're dealing with things such as Takayasu and polyarteritis nodosa, these kinds of things. And then the mimics, which are the fibromuscular dysplasia and some other entities. And the big difference is treatment. So one may require systemic treatment, one more focal treatment. So there's an example of a patient who has a little beading of the renal arteries and of the SMA. You kind of barely see the celiac artery in this case, and this is a patient who has polyarteritis nodosa. You may require biopsy to make the diagnosis. It usually happens in older women. Renal involvement is common. Also can be skin symptoms and microaneurysms. This can look very similar to this entity, an older female patient who has multi-vessel irregularities, some narrowing, and sometimes there's aneurysm formation in this entity. And this is an example of a patient who has more extensive fibromuscular dysplasia, which can affect also the carotid arteries as well. So in a patient like this, you may also look at the carotids because it can be multi-organ involvement, multi-site involvement. Another thing to look at is, although it's kind of rare to have spontaneous dissections in the mesenteric arteries, it can happen. Often it's usually a post-procedural patient, so a patient who has possibly a patient with liver disease who has had treatment for liver cancer. You can get complications, so it's important in those patients to look carefully. And again, you may not have a dedicated MRA, so you really have to look at your multi-phase images and look at the vessels there. Make a conscious effort to always track the vessels in these patients. Aneurysms are also not that common, but we will also evaluate them and can follow them with MRI very easily. This is an extreme case. The patient actually has underlying liver disease. In addition, they have very dramatic abnormalities, which are multiple visceral aneurysms. They actually have a common mesenteric trunk, so there's an anatomic variant, as we talked about before. One vessel that goes to the distribution of the celiac and SMA, and then beyond that, there's just aneurysms after aneurysm in the hepatic arteries, splenic arteries, and in the renal arteries. And again, it has implication if someone's coming and being followed for potential liver disease and potential liver lesions. Getting through all that to treat it may be very challenging. And this is an example of a vascular malformation, arteriovenous malformation. These are very important to be able to recognize, and the best way to really do it is to have the dynamic imaging that we have with MRI and time-resolved imaging to appreciate and differentiate between a high-flow and low-flow lesion. And while this may be somewhat obvious in this case, sometimes it's much more subtle, especially when it's in other parts of the body. And this can lead to heart failure and other sort of steal phenomenon. So in conclusion, I think we think about in the body more MRA is combined with MRI. It's really not one or the other. It's really trying to achieve a happy medium. And it really, MRI offers the power of not just looking at the vessels, but looking and characterizing lesions and staging disease. And being able to do that multiphasic dynamic imaging is very important. And so our opportunities really for advancement that I think about is improving the non-gadolinium sequences, which we'll hear about more, which mean improving the field of view, improving gating, increasing acceleration to make it faster and competitive with CT. Also improving more spatial resolution, also to compete with CTA, and incorporating perhaps more quantitative imaging with 4D flow and applying it to the mesenteric vessels, for example, to appreciate when you're at risk for, or when you have ischemia, for example, or when you're developing portal hypertension. These sort of things can be very relevant for clinical practice, as well as perfusion that Giles showed us a little bit about. So I'll stop here, and thank you. And I'll introduce our next speaker. Sorry. It's awkward when you're also moderating.